Good afternoon, students. Uh, Today my topic is fractures around the ankle joint. We already covered some topics regarding fractures around the femur, like the shaft of femur, all those things we have covered. So further continuing with the lower limb, basically this is still another, I think, a long question which can be asked, or some parts of it can be asked as short notes also. So this is actually a very big topic. It involves a lot of fractures, sprains, but I will just cover the things that are important from an exam point of view, like mostly the classification and the fractures, and a little bit in detail about the anatomy around the ankle joint. So this is something that is very commonly encountered again, but this is usually unlike neck of femur and all those things. This is very commonly encountered in younger populations also. So we'll see briefly discuss about fractures around the ankle joint. Uh, Initially we'll see about the significance of ankle fractures. So as we know very well, it is the most common weight bearing fracture because any fracture usually, as we know, I think we already know, some joints which are the most important weight bearing joints of the body, they are more prone to development of osteoarthritis, that we already see, like for example knee and ankle are the most common for joints which are more prone to development of osteoarthritis in old age. So that itself shows that they are the major or the most important weight bearing joints of the body. So in that sense it is quite important, because once it is incapacitated, once the ankle itself is incapacitated, it becomes very difficult for the person to walk or do any kind of activities. So that's why it's a very important type of fracture. It has got a bimodal type of distribution. Usually in men it is found to be in the younger age groups, maybe 15 to 25, 30, that age group where they are most active, like playing around, or like whatever, playing sports, a lot of activities and stuff like that. Whereas in women it is usually found to be above 60 years of age. Again, this is a very broad type of bimodal type of distribution. It can be found in any person who puts undue stress or something like that on the ankle joint. It is not usually related to osteoporosis, unlike the fractures we have seen earlier, like neck of femur and IT fracture of the hip joint, which are the main reason is of course osteoporosis in old age and all those things. But here these fractures are not usually found to be related to osteoporosis. Of course it can be related to obesity, because we know, like I already mentioned, this is one of the most important weight bearing joints of the human body. So obviously the heavier the person is, it becomes the joint itself becomes more prone to development of injury. Ankle anatomy, very briefly, you might recall, ankle is a three-bone joint composed of the tibia, fibula and the talus. Of course, mostly with the tibia and the talus. Talus articulates with the tibial plafond. Tibial plafond is nothing but the lower articular surface of the tibia, that broad flat, broad articular surface of the lower end of the tibia, that is known as the tibial plafond. So it articulates with the tibial plafond superiorly, posterior malleolus of the tibia posteriorly, and medial malleolus medially. Those are the important structures around the ankle joint. Lateral articulations with malleolus of the fibula. That is why the fibula is also part of the ankle joint, but of course most of it is made up of the joint between the tibia and the talus. So that is very briefly about the ankle anatomy. Some important things are there. One, this is an ankle joint is an example of what is known as a syndesmosis. S-Y-N-D-S, and we will just see to that. That is known as syndesmosis. That is known as a syndesmotic joint. A syndesmotic joint is nothing but a fibrous type of joint, which is held together by ligaments. Such a type of joint is known as a syndesmotic joint. So here, this is an example of a syndesmosis or a syndesmotic joint, ankle joint. So here, that is the reason why the ligaments become very important. Ligaments around the ankle joint become very important, because they are very prone to not only fracture, the bones themselves are prone to fracture, but the ligaments are very prone to development of ligament injuries. You might have seen in your daily life, like your friends or yourselves, very common ligament injuries around the ankle joint. So in that sense, ligaments are quite important. So here you can see the anatomy there. You have got the posterior talofibular ligament, the calcaneofibular ligament, anterior tibiofibular ligament, anterior talofibular ligament. These are again the important ligaments, and of course the deltoid ligament. These are some of the important ligaments around the ankle joint, because it's quite common to injure the ligaments around the ankle joint. That's why they are quite important. So along with remembering the major components of the ankle joint, we also need to keep in mind the ligaments around the ankle joint, because they are also very prone to development of injury. So they have the lateral ligaments as well as the medial ligaments. So here the deltoid ligament is quite popular as far as the injuries and all are concerned. So that is why it's a type of a medial ligament on the medial side of the ankle joint. So that is why the ligaments also are quite important. Joint is considered saddle shaped. As we know very well, there are different types of joints like ball and socket joint and all those things. I think you already remember different types of joint and all those things. So here this is an example of a saddle shaped. The dome itself is widened anteriorly and posteriorly, and as the angle dorsiflexes, the fibula rotates externally through the tibiofibula syndesmosis. That is just briefly about the movement around the angle joint. So basically, when you dorsiflex the ankle, as you know very well, the dorsiflexion is one of the most dorsiflexion and plantar flexion are important movements around the angle joint. So as the angle dorsiflexes, the fibula rotates externally through the tibiofibula syndesmosis. So like I already mentioned, these are the important areas of the talus as well as the lower end of the tibia, which are important anatomical landmarks as far as the angle joint is concerned. Very briefly about the biomechanics, it has got a very complex motion. There are quite, just like a hip joint, for example, it is quite a few, quite a few complex movements do take place around the angle joint. The normal range of movement is around 20 degrees of extension, 40 degrees of flexion, 30 degrees of inversion, and 15 degrees of eversion. Again, anatomy, you have learned all these movements. So extension, flexion, inversion, and eversion. These are the important movements that are taking. Of course, other joints are also involved in the movement, like for example inversion and eversion and all that, but the angle joint is one of the components which is responsible for all these types of movements. At least 10 degrees of dorsiflexion is needed for normal gait. So that is important, like after a fracture or if the angle joint has to be immobilized, we always make it a point to keep at least 10 degrees of dorsiflexion. Then only the person can walk kind of normally. So that is why that is an important step. So at least 10 degrees of dorsiflexion is needed for a normal gait. 1 millimeter of lateral talus shift decreases tibial surface contact up to 40%. So basically that's what happens here after the fracture, after correction and all those things. If there's a talus shift, if the talus shifted, that's very interesting point of interest you can remember. It decreases the tibial surface, that is the surface of the joint itself, by up to 40%. So you can imagine even a slight shift can result in that much of loss of angle surface or a joint surface. So that is very briefly about the biomechanics of angle joint. Coming to very briefly, before we go into classification and all those things, how do you physically examine a patient who you suspect to have some kind of angle injury? Obviously, you can, first of all, you can note the obvious deformities like maybe swelling and all those things, redness, edema and all those things you can observe. Neurovascular examination, this is another type of very common. Along with angle fractures, you usually get some kind of neurovascular compromise. So you need to examine the patient for that also. Pain. Obviously, you can palpate and see for the pain of the malleoli as well as the ligaments. Then you can palpate along the entire fibula to see if there is any other injury along with it. Pain at the angle with compression, that is known as syndesmotic injury. What happens is, if you apply compression at the angle joint, there will be pain. And examine the hindfoot and forefoot for associated injury. So obviously, when you suspect there some kind of injury on the angle joint, all the other surrounding structures also you can examine for any kind of injury. So that is very briefly about that. Coming to X-rays, as you know very well, again, just like in all major bones of the human body, AP and lateral views are very important as far as the angle joint is concerned. But here, in the case of angle, one more X-ray is important, that is known as a Mortise view. We'll just see that what exactly it is. So it is known as a Mortise view. So AP and lateral views as usual. Along with that, it is known as angle mortise. That is an X-ray of the angle mortise. That is the entire structure of the angle joint, the bones and all forming the angle joint. So an X-ray of the, it's known as a Mortise view. So Mortise view is also important. So these three are the important views of the X-ray as far as angle joint is concerned. So here you can see the difference there. What exactly is a AP view, Mortise view and a lateral view. AP view and lateral view, I think you are already familiar. So here what happens is the Mortise view, as you can see here, it is specifically showing, as you can see, that angle joint. It is nothing but internally rotated angle joint. Around 15 degrees, you are rotating the angle joint. That's why some fractures or some kinds of injuries become clear only with a Mortise view. You will not be able to observe it straight away with an AP view or a lateral view. That is why this kind of view is important as far as angle joint is concerned. So that specific type of view or special type of view is what is known as a Mortise view. So these three views are important as far as angle joint is concerned. So it is nothing but so anteroposterior view, what are the things you can notice? If you these X-rays which we saw, they are actually normal X-rays. All three views. Here we will just discuss some of the abnormalities. It is nothing but in AP view, what happens is you look for a tibiofibular overlap. Less than 10 millimeters implies syndesmotic injury. Tibiofibular clear space, the distance between the tibia and the fibula. More than 5 millimeter implies syndesmotic injury, and a talar tilt, which I already mentioned earlier, the tilting of the talus as a result of the injury. More than 2 millimeters is considered abnormal. So in an AP view, these are the things you can check for: tibiofibular overlap, tibiofibular clear space, and talar tilt in an AP view. In a Mortise view, I already mentioned AP view, it's nothing but an AP view with the foot internally rotated to about 15 degrees. So you take a normal AP view but with the foot in internal rotation to about 15 degrees. Then you call it a Mortise view. So here, what are the abnormal findings? You can go for medial joint space widening or the tibia-fibula overlap. Just remember some points if you want. That's all for academic interest. So these are that's exactly what is special about the Mortise view and the things you check for in the Mortise view. Lateral view, obviously some things like the posterior malleolus and all those things, no? Like for example, posterior malleolus fracture, subluxation of the talus, angulation of distal fibula, talus fractures, calcaneal fractures, all these things become clear only on the lateral view. You will not be able to observe these things on the AP view or the Mortise view. That is why lateral view is also important. So some things like specifically talus fractures, calcaneus fractures associated with the angle injury and specifically the posterior malleolus view or fracture. These things are visible only on the lateral view. So that is why all three views are important as far as a suspected angle injury is concerned. Other imaging modalities, as we know, is something called a stress view. That is something called a gravity stress view, manual stress view. Basically, you are pushing the angle joint, or you can applying pressure to the angle joint and taking the X-ray. So some specific injuries you may need to go for all these views. Then of course you can go for a CT scan and MRI. Some important points like joint involvement, posterior malleolar fracture pattern, preoperative planning, like evaluating hindfoot and midfoot. All these things you can actually go for. Suspected soft tissue injuries, neurovascular compromise. All these things you can always go for a CT scan and MRI. Like for example, MRI, ligament and tendon injury, talar dome lesions, syndesmosis injuries. All these things you can actually go for CT and MRI. But of course the mainstay is all the three views which I already mentioned earlier. Coming to classification of angle joint, angular fractures, this is one important point. They might ask you as a short note or something. Most important is Log-Hansen classification, the first one that is mentioned there. Second one is Davis-Weber classification, and the third one is AO classification. So, but here, most commonly asked and most commonly used in day-to-day practice is what we call the Log-Hansen classification. We'll just see briefly about those things. Before that, we'll just go into, before we go into the classification, this is just showing some kind of fracture line. What exactly can make out, it depends on the fracture line. What exactly is the shape of the fracture line? Based on that, you can call it a push-off fracture or a pull-off fracture. So you can see here, on the left image, it's a push-off fracture. So basically, push-off is nothing but an oblique or vertically oriented fracture indicates a push-off fracture. You can see here on the left side, it is an oblique fracture line, as you can see there, of the lateral malleolus. You can see that fracture line there, no? So that is the push-off fracture. Whereas a transverse or a horizontal fracture, on the right side you can see the medial malleolus is fractured. There you can see a clear or a clean transverse or a horizontal fracture. Then you call it a pull-off fracture. So if it is oblique of the lateral malleolus, as you can see, it is a push-off. Whereas the other one, it depends on the mode of injury and the type of forces being applied to the angle joint. So on the right side you get what is known as a pull-off fracture. That is the clean transverse or what we call a horizontal fracture line. Then you call it a pull-off fracture. So just for you can remember like that, there's two types of forces which cause these two types of fractures, push-off fracture and pull-off fracture. Then it shows stability. This is just a diagram showing how stable the angle joint is going to be after the fracture.